So we have a lot to talk about today, and we're going to be spending the most of our time talking about benefits, a little bit about cost sharing, as obviously they're really related to each other. Since this is a public meeting, why don't we just take a few minutes and just everybody can introduce themselves for the good of those who are on the meeting and for anybody watching the recording later. I'm Sarah Nipper. I am the OHA staff that is supporting this work group. Glendora, you want to kick off the tag introductions?
Okay, hello everyone. My name is Glendora Claybrooks, and I work with Sarah in leading the eligibility, benefits, and affordability advisory group. And welcome to our 6th meeting. And at this time, we will allow for introductions of the other TAG members. So let's start with Dr. Junkier.
Glendora. Hi, everybody. I'm Xenia Jankiri, she and her pronouns.
Hi, everybody. I'm Ed Junkins. I use he, him, his pronouns, and I am from Western University of Health Sciences. I'm a pediatrician. I live in the Corvallis area, and I serve as the vice chair of the Joint Task Force in Universal Health. Thank you.
Michael?
Good morning. This is Michael Collins, Confederated Tribes of Warm Springs Director of Managed Care. He, his, him.
John?
John is our guest this morning, I think.
Oh, okay. Sorry about that.
I'm a listener. I'm a listener.
Okay, I see you all the time, and I'm not looking at my membership enrollment list. So
I think
We got Sharon.
Dr. Stanfill, yeah.
Hi, good morning, everybody. Sharon Stanfill. I'm the Chief Health Officer for the Cow Creek Tribe, pronoun she.
is that it for our membership, Sarah?
That is it. I know it's hard. Everyone's in all of these overlapping groups. It's hard to keep track of everything. So thank you.
Exactly. So the rest of our agenda will be addressing eligibility and enrollment. We'll have a benefits discussion. And as Sarah has said, we'll talk about cost sharing and affordability. Then we'll have some inquiries and input around the community advisory committee. Then we'll have public testimony. So at this time, I'm going to defer to Sarah.
Thank you, Glendora. Before we get started, is there anybody here right now who knows that they would like to give public testimony at the end of the meeting? If so, could you please unmute yourself and speak up? Okay, not hearing anybody. I will check again later towards the end of the meeting. So Glendora already reviewed the agenda that we're going to be going over today, and mostly spending the time on benefits, talking a little bit about affordability and cost containment, cost sharing as well. But the first thing I wanted to do was just give folks an update on the eligibility and enrollment draft proposal after our series of conversations in this tag, and then we did, I did present those overview slides at the last task force meeting. So I worked with Dr. Junkier on a proposal based on the tag meetings on issues of eligibility and enrollment. It's really it's a more detailed version of those slides that were presented at the task force. I did not hear any feedback from other task force members after that meeting about those slides. I don't know if anybody else in the tag heard from anyone else with questions or concerns that any other task force members had. Did anybody get any feedback that they want to share? Okay.
So sorry,
yeah.
Sarah. Specifically feedback about
So the eligibility at the last task force meeting, we spent the bulk of the time on the provider proposal, but I
Right.
did go over the eligibility and enrollment slides that presented a high level preview of what the EBA recommendations would be related to eligibility and enrollment. And so had left the door open for task force members to send questions or comments or feedback on those. And I didn't hear anything. I just wanted to see if anybody else had heard from any other task force members. Okay. So based off those slides, there is a draft proposal, and that is going to be sent out to you all today or tomorrow for you to review. Really tried to stick very faithfully to what the tag discussions had been, to make clear areas where there was consensus and places where there was not consensus. So that's going to go out to you over email, and if you could please review and send comments back to me by the 17th, which is a week from today. We will then be presenting this proposal, these recommendations, to the task force at the next meeting. Oh, this says February 28th, but I think it might be the 25th. Similar to what happened with the provider recommendations the last time, this time we'll be focused on the eligibility and enrollment. And we'll also be asked to give a high-level overview of today's conversation about benefits. So I just wanted to give you a little preview of what this is going to look like. It's going to be a straw proposal with an outline of the process, what the values are that we had talked about before, and then sort of this table format where the recommendations will be in here, some rationale and justification, and then additional considerations that we just want folks to be aware of, whether it's other tags as they're taking these recommendations into account or the task force writ large. So you will have the full document of this, and I will email it to you, like I said, today or tomorrow at the latest for you to take a look at. And then lastly on this piece, this is a slide that was presented at the task force meeting, but I wanted to present it again because I wanted to make sure that folks were aware of kind of the timeline that we're operating under here. I mean, we've talked pretty extensively about how there's really some time pressure and not enough time to probably do as thorough, have as thorough discussions as we would like to have, but under the requirements that we have to be done at this point by June, this is the timeline that we have settled on. So in the January meeting, I did give a preview of eligibility and enrollment. At the February task force meeting, we will be discussing the fuller proposal. So after you all have reviewed it and given your comments, I will incorporate feedback and send that to the full task force and then present it to the full task force. We are also being asked to give a preview of the tag's discussion on benefits and affordability, which is what we're talking about today. So hopefully we'll be able to, I don't think we're going to wrap up this discussion today, but we'll be able to have some high level updates that we can provide to the task force in February. In March, the task force is going to be asked to adopt the eligibility and enrollment proposal. I think we need to maybe rework the timing a little bit here on benefits and affordability, but we can sort of have some offline discussions about the process for that, partially seeing how far we get today. So that is the next couple of months as far as our timeline for where we are at. We have one more meeting on the calendar in March, and I'm hopeful that that can be the last meeting for this tag, but we can evaluate that sort of at the end of today and see where we're at. Are there any questions on anything about the timeline, or comments or concerns about the timeline and the what I just talked about with the proposals?
Yes, this is Glenn. Sarah, can you just clarify for the public, when we talk about benefits and affordability, is that specifically applied to the population at large, or the state, or both? When we talk about,
oh, you mean, is it affordable to the state versus affordable to the consumer? Is that what
yeah,
you mean?
the benefits and affordability, yeah, is that applicable to both
No.
state and population at large, or just the healthcare consumers grouped as the population at large?
So so it's focused on the population. So we're talking about what are the benefits, like the conversation we're having today, what are the benefits that like the healthcare benefits that would be part of this plan. And then cost sharing and affordability is really focused on cost sharing and affordability for the consumer, for the individual.
Okay.
Finance and revenue is really responsible for thinking about, can we afford all of this? Although it's something that, as we've talked about, all the tag topics are somewhat interrelated. But yeah, affordability and benefits for the consumer.
Okay, thanks.
Yes.
I've got a quick question. This is Xenia, and maybe this is to you, Glendora, as the chair for the CAC. Do you feel like this is that the CAC has had enough time to provide, meaningful input and, kind of digest the work that we've been doing on this proposal? I want to make sure that we're not, tokenizing the CAC, and that if we have CAC input here, that we've really been able to spend that time. So I just wanted to name that and ask, I think, what your thoughts are.
Yeah, thank you, Dr. Jonkier, for that. I think to this point, CAC has provided meaningful feedback to the tags based on the questions received. So they are a pretty knowledgeable group with respect to the questions heretofore they've been asked to weigh in on. However, there are sometimes, I think, questions from the tag that exceeds the knowledge level of the majority of the CAC members. However, that there are a few on there that have the understanding and the knowledge of in-depth knowledge of the topic to weigh in with meaningful feedback. So with that, I will say I try to, as the chair, control that those questions that I deem inappropriate or exceeds the skill and knowledge level of the CAC. And how I assess that is through the criteria that we examine in selecting our CAC members. I look back at that and I say, okay, well, that was not one of the criteria that we use to select our CAC members. Therefore, I don't see them having the knowledge of the topic in order to address a particular question from the tag or task force in a meaningful and effective manner. So thank you for that inquiry. And so that, just to let everyone know that that is my that's my approach in how I try to oversee and guide and direct and stimulate provocative thought and responses from our members, advisory members. Did that answer your question?
Yeah, it did. Thank you very much, Glendora, and thanks for your leadership with the CAC. I just wanted to make sure we were, able, that they felt that the CAC felt like they had opportunity to provide meaningful input. And it sounds like they not only have that, but there's also capacity, skills, knowledge, et cetera, where they're bringing up questions that actually exceed the conversations that we're having in this space. And so I'm sure you're bringing whatever learnings are important for us here and trying to figure out how to hold the balance of those conversations. So yeah, that answers the question. Thank you.
Okay, thanks. Sarah, I would just like to say I'm having the same problem with my screen dancing, and I may not be, and so when it starts this, I have no control over my selection processes such as mute, unmute, and that sort of thing. So I don't know what's going on here. It just happens only when you are presenting or Laurel or someone, and then takes over. I have no control. So if I don't weigh in, it's because I cannot make selections to raise my hands or mute or whatever. Okay.
Okay. I don't know if you want to try leaving and coming back in if you think that would help, but definitely if I notice that you're very silent for a while, I'll check in on you.
Well, the only reason I'm able to you're able to hear me now is because I was unmuted before it started to happen. So right now I can't even, I don't even have the option to leave and come back because my selection tabs are just non-existent at this point.
I see. Okay. Thank you for letting me know. And I hope that it rights itself here.
I guess I'm the only one with this problem, right, team? Oh gosh, Murphy's Law, darn it. Carry on.
Okay. So we're gonna spend the bulk of the time doing this benefits prioritization as a collaborative exercise. Before we do it, I wanted to just do a little bit of framing and teeing up what I'm hoping we can get out of this today, and what I think it might be useful for and not useful for, and then get your feedback on that. So I wanted to put back up the guiding values that EBA decided on when we were talking about eligibility and enrollment, which is that recommendations be equitable, inclusive, simple, and comprehensive. I think one of my hopes as we're going through the benefits process is that there are other, not necessarily values, but other commonalities, other principles specifically regarding benefits that we might be able to pull out of different people's responses. But it seems to me like these 4 values would be something the TAG would support across all the discussions, whether it's eligibility, enrollment, benefits, or affordability, that we would want these to be the guiding values. So I wanted to just put those back up there. Wanted to also just give a reminder again about what Senate Bill 770 says about requirements around benefits. So the legislation says that the proposal must preserve the coverage that is currently required by Medicare, Medicaid, CHIP, and the ACA, and that the final report is supposed to include criteria to guide the board in determining which healthcare services to offer, including, it may include things like, whether they're covered by PEB or OEB, state employees, are they designated as effective, whether that's by professional bodies or peer-reviewed medical literature. There can certainly be other criteria, but these were just some examples in the bill. So for today's activity, we're going to go through this prioritization activity collaboratively. I know some of you did this on your own already, which is great. I think there's a lot of benefit to doing it together and seeing the kind of conversation and discussion that stimulates. I'm hoping we can identify areas of consensus and also difference in tag member approaches and sort of what is guiding your decision making, your recommendations, and then use those observations to begin developing benefit recommendations. I want to be really clear that the tool, the different levels and the examples are certainly not intended to represent the full range of options or even necessarily specific options. The intent is not that we are choosing between low, medium, and high in order to designate a benefits package. The purpose, I hope, is to get people thinking about what is most important to them and what is maybe less important to them. Where do they think this plan would be best served by having, richer benefits in certain areas versus maybe not other areas. So I know, Glendora, was you saying earlier that this really brought up a lot of passion for you in doing this discussion, and I think it's working if it's getting you to think about where are those tensions and where are the places that you feel really strongly and passionately about. Because I think ultimately we want to know those things so we can bring them forward to the task force and the other tags as they're doing their work as well. So that I do not expect we're going to be choosing one of the outlines in the activity. It's more really for stimulating discussion.
Can I ask a question, Sarah? This is Enya.
Yeah.
So I really appreciate that there was a conversation early on about the stimulation of passion from this activity. I really struggled with this activity. I felt like who am I to be in a position to determine whether or not people receive services, which is essentially this, right? We're talking about pegs, but we're also talking about individuals and services that they will not be able to receive if I don't place my pegs in a particular category. And it felt really, really hard. Like I didn't even want to share my results because it just felt like it felt like too much responsibility. And I also worried that we were already, like, I was thinking about our bookends. Like, what are our bookends? Why are we doing this activity? Why aren't we just, offering all of the pegs and then asking the, finance team to figure out how to finance it, right? Are we already limiting ourselves because we're concerned that we won't be able to fund we won't be able to fund all of the services that we want provided? And so I'm wondering if someone can just kind of provide me a little bit of context for am I thinking about that correctly? Or we're doing this activity because we believe that there's just no way that we're going to be able to fund all the services? I see Ed got a reply. Thank you.
Oh, I'm hoping Sarah has a better reply than what's crossing my mind. But I wanted to pile on, if you will. I too found this difficult for similar reasons. And I also saw that if there were enough people doing this sort of activity, I actually shared the activity with other people from the HAC down in my area. That the Mid-Valley group is presently, individual members are going through this activity. Understanding that the Senate Bill 770 has a requirement that we preserve services, and that there isn't an infinite pool of money and there aren't infinite resources, and that my hope is that my perspective along with others' perspectives will help us as a group start to set some priorities and dialogue that will help build out the frame of what we value, that we can pass along to the task force and to the the revenues tag, because we're going to run into a situation that where we don't have all the resources. And yet ideally, in order to get people on board and get people to look away from maybe federal programs or look away from private programs, and actually see the value in this so that our pool is big enough that it is a robust benefits package that, there is a lot to offer. So 55 pegs I struggled with. I did the activity over and over and over again, moving my pegs around. And I kept telling myself, this is so that we could have a meaningful discussion. And I'm just part of that. So for what that's worth, I'll throw that on there.
Yeah, I really appreciate that. And Dr. Junkier, I think, absolutely going through this too. I mean, I did it myself just to go through it as well. And there is a little bit of sense of like, our role here is not to like play God for people in terms of saying, what do you deserve and what do you deserve? So I really do understand that intense discomfort. And I think that it really reflects, I think, back to the values of the tag, which is that things should be comprehensive and equitable and inclusive. And the nature sometimes of designing benefit packages, designing this whole thing is that there are boundaries, there are limits, there are bookends, I think is what you said, which is a great way of putting it. So 55 is a number that I made up, basically. It is not, there's nothing magical about it. I think the point is to work through some of those conversations in your head and collaboratively. So I think it is fine if the tag's response is, this is not acceptable to us and to our values. Like this number, this magical number is not magical. So we are going to say, what we feel like is the minimum is like, whatever it is, this is what we feel like needs to move forward. And that's okay. I just think that it's coming from a place of like having thought through it and kind of grappled with some of those issues. So, and I'm going to say one more thing, Glendora, and then go for it. I think the other thing that I just want to be really responsive to is, I think the reality is that if the tag said, we want everything, we want to put all of the markers, we want all, the maximum services, and said finance and revenue, figure it out, figure out how to pay for it. What I'm concerned about is that really puts the values and the control outside of this tag. And so if those choices are going to be made, and some of those choices need to be made, I want to make sure that the values and the principles of this tag are reflected in those hard choices. And so just handing it off and saying, figure it out, I'm afraid it really takes some of the autonomy and authority out of the hands of the people that are sitting on this tag, if that makes sense. Okay, I'm done. Glendora.
Thank you. I'd just like to ask, Sharon, are you a doctor too? First question. Because I want to respect your credentials. That's why I ask.
I'm a public health doctor, so I do. I do preventative care.
Okay, all right. So,
yeah.
Okay, so
you're
doctor,
good.
thank you. So doctor, I'd just like to ask before I weigh in, if you would have any input, and so then I can follow you.
This is a great conversation, and this is exactly what our tribes and why I think that probably Michael and I are sitting on this committee too, is for the very same reasons, the very same things that you folks are all bringing up. So we're right here with you, but I have nothing more to add, but I'm really loving the robust conversation and in full support.
Okay, Michael? Michael there?
Yep. So, good morning. Yes, I agree with the dialogue that we've had so far this morning from Dr. Junkier, Dr. Junkins, and yourself, and Sharon. And I think we're going in the right direction. I think it's always hard to say what kind of accomplishments we're making or progress we're making, because it seems like when we're in these, and this is not just here, but everywhere, we're kind of piecing it together, but miraculously at the end it falls into place, and I think it's right where we're going the direction we need to go.
Okay, thanks, guys. I would just like to give a quick overview of this process, and it's going to be piggybacking off of areas that each of you have mentioned. First off, I see this as a non-comprehensive benefits approach, okay? And this is what we are trying to accomplish in the design of the healthcare delivery system, is a comprehensive approach based on existing existing benefits and or lack thereof. So I saw this, I couldn't even get past the peg. I wasn't going to play that game, because when I read the instructions and I read the purpose for which we were doing it, I just completely went ape wild, right? And I thought that for number one, the process is too subjective to be fair in decision making. I thought that the clients should be determining their own needs, working in unison with whomever will be authorized to provide the services or recommend the services, right? So I thought that because of the subjectivity, it would promote racism, classism, and other social discriminations among people, because I have endured this as a person of color, not always with private insurance, and having people make decisions and recommending resources and services and treatments based on the color of my skin and their implicit racial bias, right? So I saw this, if we're going to be focusing on these kinds of tasks, then it's still another method of excluding. And when we start to exclude certain certain social situations and people, and making subjective decisions, thinking that we have the best interest of those we're serving in mind, is another way of trying to exclude particular services that's going to lower the overall cost, and then claim our objectives have been reached within the system. And within the system, I'm talking about the OHA, the agencies, the DHS, and things like that. So it is this kind of subjective authority, if you will, that gets us into trouble. So, I interpreted this method as being based on a cost-benefit analysis, and I come from the school of thought that the benefits must always outweigh the cost. And we are so heavily committed and dedicated and engaged and talking about what is it going to cost, what is it going to cost, and then we offer these trickle down benefits that never trickle down to the entire population at large, including minorities and rural residents, and we never get where we're supposed to get. So as a member, I am feeling like this is not quite the best pathway to, even though it's well intended, it is not what I perceive us to be having to participate in because of its subjective nature. I don't want to apologize for going too long, but I have to feel like I've done a good job of expressing my, insight and input and experience without insulting anyone. That's my aim. So I'm done. Thank you.
Thank you, Glendora. So, okay, I'm hearing some really, strong reactions and I think really grounded concerns of this as a process. So I guess, we were going to go through this together. What I'm hearing maybe, well, I'm gonna put a couple options forward and see what people think. So one option is we can do this together, as I was anticipating, or as I was planning on doing. The markers itself, the number of markers is sort of whatever, does not have to remain as is. We could modify it and still do it together. Another option is we could look at a richer benefits package, like what state employees get, how that, I had put in the one I had sent you, like what the basic Oregon benchmark plan is. I've also done it myself, but marked to what is the PEB, what is the state employee plan, and start from there and see where people think that this falls short of where you would like to go, or where there are places that you would like to add on to that. That is another option. A third option is to just really have this as a much more fluid discussion where, going back to kind of the original comments of there's a discomfort and folks don't feel like it's appropriate to necessarily make these kinds of limitations. So then the question is, what do we put forward to the task force around around what guides benefit selection? Because we can build it from the ground up, essentially. I'll just say that my one thing I do want to keep in mind is what I brought up earlier, which is if we put something in somebody else's hands and this tag is out of that discussion, that really puts the control in somebody else's hands. And so that I feel like that's going to lead to some outcomes that people are maybe not going to feel good about. Yeah, Dr. Jenkins.
First of all, I appreciate what you're doing here with us, Sarah, and I acknowledge my colleagues' comments. At the end of the day, we have until mid-March to present something, and then we turn this over, and it's up to the group or it's up to somebody else to answer the same question Sarah's asking of us. It's a hard question, and it may not be a fair question, and you can interpret it through whatever lens you want. I've been doing diversity work, and I've been championing the healthcare and the outcomes of the underserved, and people of color for decades. And I feel like I view procedures and processes with that lens in place. And at the end of the day, we are still talking about benefits which affect everybody. regardless of where you think it's coming from and regardless of where you think it's going, somebody's going to have to make this decision. And if it's not us, it's going to be some other group. And if it is some other group, they're going to have to start somewhere. We don't have a whole lot of time to be doing a couple of those options, which is to be philosophical about this or to be ground up. In fact, what you are presenting to us is much more of a ground up approach where we're assembling what we think would be ideal. Since we are not doing this individually, we're very exposed now as a group, making very public decisions out, in the open, which is harder for us individually. But that's the path we chose by not participating individually for whatever reason. I am in favor of maintaining some decision-making authority or control within this group and providing some kind of recommendation as far as prioritization forward, because it's going to have to happen. And if I were the task force, I'd look at our group and say, what did you guys decide? So I urge us to adopt some kind of procedure to get this work done. And I'm for whatever, Sarah, whatever you ask us to do, I will react to.
Okay, thanks, Dr. Jenkins.
Well, I'm not quite so sure that whatever Sarah asked for, I'm willing to do. However, it doesn't mean that I'm unwilling to cooperate. But what I see is a repeat of what I have lived with. Dr. Ed, I heard you say you've been studying this for decades. Well, for over 6 decades now, I've been living it, right? And so
Glendora, can I just ask you? We understand that. Could you please present another option? Let us know what let us know what to do.
Just give us time. And I think, Dr. Ed, with all due respect, sometimes we want to jump into the solution before we jump into root cause and defining the problem and analyzing the problem. So I work in a methodological manner, and sometimes people get, and the way that I try to present things may not be in the same manner in which others are used to hearing it. So just bear with me here. I'm not trying to be a know-it-all. I'm speaking from lived experience as well as my academic training and professional, skill set. So what I'm saying here is that I think knowing that the problem is ineffective healthcare coverage that that results in lives lost and people not receiving the kinds of quality services that they should be, and still the cost of healthcare is on the rise. So considering all of those things, I think that what we should be doing is analyzing the existing services and benefits in place and the cost. And we already know that the cost, out-of-pocket cost for the population at large is just uncontrollable, and it is and making our system non-sustainable. So I think in order for us to get to the kind of design that can achieve comprehensive benefits at an affordable price, then we need to start analyzing what do we have in place, what is working, what is not working. And I don't see this project as enabling us to start there, to get to that juncture. So I would love to see us start to analyze the existing policies in place and what will it take for us to either eliminate or improve those policies, and who should we be consulting with in order to help us get there. I do not see the EBA tag relinquishing anything. However, I do see us forging a pathway that is going to allow us to make analysis that's going to inform us about current issues and to prepare us to fix, you know, to design a policy that's going to be an improved one with regard to benefits and affordability. I hope that makes sense, Dr. Ed. That's the solution I'm proposing. That's how we get to the solution, is start to analyzing the existence of what's in place, why it has not worked, and what we need to do to make it work. And is it appropriate? And will it meet the needs of the public health needs and the healthcare consumer needs? Does that make sense? I mean, is that a start? What do you think about that?
So if I may, Glendora, I think, you know, going back on the slides, looking at if you're talking about what is available now through the current health system, you know, OHP utilizes HERC's approved lines for what's covered. So we need to decide for benefit factors on, are we going to expand that through HERC? Are we going to include other things that are below the line that should be above the line for pay? And who's going to do that? Is that going to be this TAG's recommendation to look into that? Or are we going to actually look at the list and say what that is? This is a big, the benefit part of this is the big part of it. The eligibility, we kind of got worked through that. Now we're in the benefit part of it. And we need to understand that there's other entities on that one slide. It showed those through the, reminder what 770 says about the benefits of slide 11. You know, it goes into there for the Health Evidence Review Commission, the ION committee, in those areas, and that's right in 770. So we need to, when we're talking about benefits, understand all of these placeholders of how we are there today and how we know it doesn't work, and what are we going to do as our recommendation so that we can make it a better health system. Because if we stick with the same list, it's just a different page. And then if we want to look at another factor of that in, if you can go back out to where you were, Sarah, where it showed the slides on the side there. If we go back to slide 14, I believe it was, where you talk about these other areas, you know, co-pays if they're a Medicare patient. Of course, I believe the Universal Health Task Force should pick up the co-pay on that, because the patient shouldn't have any out-of-pocket expense. If you look at prior auths, that's a big thing right now. Prior auths can be detrimental to people's health, waiting for that prior auth to be authorized. We need to look at those as part of this benefit and how we do that. I'm a big proponent of SDOH. That's huge in our field of work. And then your limit of services, you know, the medical limit of services, I don't think there should be a limited service for necessary medical procedures, where you're talking, I think, limited of services per year. You know, right now we have limitations on what dental services you can have per year, what other holistic health approaches you can have per year, whether that's physical therapy, occupational therapy, acupuncture, those types of holistic health services. These are things that we need to really vet out in this tag, at least as a recommendation and moving forward. I think sometimes we get caught in the minutia of things, and that's fine, but I don't. And then I've been saying this from day one. Time is of the essence. So that's kind of my two cents there. We need to move forward in getting to the meat of what our recommendation is going to be.
This is Xenia. I'm really appreciating this conversation, and as much of the internal struggle as I'm having right now, I appreciate being in space with you all to have these discussions. I'm thinking about the conversation, and I'm thinking about, what you said, Sarah, which is a real concern and is a concern of mine too. And that is, if we send all services, all people to the finance group, and then they say, well, we can't actually finance all services, all people, so we're going to just go ahead and cut this down to make it fit what we believe we can finance. I think the fundamental issue there is that clearly our tags are not aligned under the same values, right? Because if we were aligned under the same values, then the finance tag wouldn't say, we're going to cut it to fit this, whatever we think we can finance. I think the finance tag would say, we need to be creative and figure out either how to finance this, and or like, what are the additional, where are there either additional pots of money or ways to finance it? I just worry that getting everything to the finance committee and then have them having some already preconceived notions of what that kind of, container looks like, means that we're not necessarily working at our most creative level, right? If and I've heard this from, the national experts who have come to speak, and they said, good luck, you all, you're trying to do something that no state has done before, right? Other states have tried this, they've tried that, but you all look like you're really trying to do something different. And I believe we are. We're trying to be creative. We're trying to do something different. If we're trying to be creative and do something different, and if we are aligned in our values of all services, all people, then we should have no committee that says, okay, we're going to move these services or these people out because we just can't figure out how to finance it. That, to me, it feels a little bit like a cop-out. I think we need to figure out how to finance it, right? If it's going to cost, 5 times more than we thought it was going to cost, then I think we just have to figure it out. And I know that sounds easier said than done, but I think if we don't do that, then we're not living into our values. And if we get to a place where we're like, we can't figure out how to finance it, then maybe it's worth going back, whether it's the legislature or whomever, and saying, we can't figure this out right now because it's going to cost too much money, and we don't believe that our values will not allow us to let communities and services go in service of a politically feasible plan that continues to leave people out and doesn't allow folks to have access to the services that they deserve, right? And so I recognize that's a theoretical statement, and also I think it's an in practice statement. I think that if we're going to do things differently, we need to do them differently. We need to be as creative as possible. And so I wonder if, thinking about Glendora's comments and Michael's comments about, maybe specific policies and practices, I wonder and I really appreciate this activity for stimulating this conversation, but I wonder if there are conversations that we want to have within the bucket areas that you laid out in the activity about current practices that are working well, maybe current practices that are not working well, and then focus on either what's not working well and or leaving what is working well under the buckets, whether it's SDOH. Okay, currently there's no funding allocation for SDOH. Great, we want to make sure that it's included and includes these things. Under long-term care services, here is the issue, costs a lot of money, oftentimes money isn't allocated, we want to make sure the money's allocated, etc. And I just wonder if that would at least move us a little bit closer. I don't think it's going to get us closer to the finance tag having something that is most politically feasible, but I do think it's going to get us to a place that's in line with our values.
Thank you, everybody. That was really helpful, I think. And Dini, I really do appreciate, I like your suggestion of maybe going into some of the categories and talking about what's working, what's not working, and what people really feel like needs to be part of what would it even mean to say all services? What is all services for all people? Ideally, what does that even look like? Because I think, and I'm just throwing an idea out there that maybe somebody at OHA is going to be not happy about, but you know, maybe we would want to have a joint meeting of the EBA and the finance and revenue tags together, and have EBA basically say, these are our values, these are our ideas, this is what we want to move forward, and let finance and revenue grapple with that and ask questions and sort of actually be able to have some dialogue and exchange about that. Because, you know, I think Zena, you're right. This is one task force, right? Everybody's serving on the same task force with the same goals and the same objectives. The conversations in these areas are really different, I think, even as far as whether we're talking nuts and bolts money or whether we're talking about values. And at the end of the day, this report needs to reflect the totality of the task force conversations. So rather than having the trains running on tracks that are diverging in different directions here with EBA tag and finance and revenue, my metaphors are not quite working here, but does it make sense to bring folks together at a certain point and have a joint conversation? So
Yeah, I agree with you there. I think that's an excellent idea. Yeah, I think we get a little bit further progress here, and then we can maybe have a meeting with finance or some other tag that we find necessary. I think having a joint collaboration to make sure we're going along the tracks together.
okay. So given that, why don't we, thinking about the question, what would all services for all people look like? What does that even, you know, what does that mean to this tag? How would that be aligned with the values and the goals of the tag? I'm thinking we can have, I mean, I had sort of set up this brainstorming activity, but I'm thinking maybe if we start broadly with what does that mean to you? And then we can kind of move into some of the service categories. Because I think some things are pretty straightforward, like, you know, we're talking about coverage of lab and x-ray services or whatever. There may not be a lot there. But if we're talking about social determinants of health, which is a pretty new type of coverage, you know, the CCOs are just sort of dipping their toes into that now. What would that mean for this tag? What would it mean to say, we want this bucket of things to be covered in this plan? So I'm suggesting we start broad and then maybe talk about a few of the specific service areas. What do people think about that?
Xenia, I like that idea, and I'm wondering if maybe we also want to focus on the areas that are currently not covered by OHP, and then maybe Sarah, even if you can help us understand what is not covered by the more expansive plans that you did the activity against. That way we can focus on what is not currently covered, whether or not we want to cover that, and then it may be easier to talk about some of the things that are currently covered, but I don't know how that lands with the rest of my task force members.
Yeah, Dr. Jennifer, that is exactly what I think would strengthen our discussions and way forward. We need a starting point from which to evaluate and identify what is needed in order for us to meet these categories of eligibility. And I think one of the things that I think stands out in my mind is that eligibility simply is everybody in, nobody out, period, right? So let's stop putting a limit on the kinds of health needs that people have and whether or not they should be considered as primary or secondary or tertiary or whatever. But just when people are ill for whatever the physical ailment is, they have access and to a medical intervention without limited services and treatment. That's what makes them eligible for all services. So I think, yeah, evaluating what is happening now in order to be the most inclusive, and so that we can live up to everybody in, nobody out mantra. And as far as the benefits, make sure that we have the mental health, the and the dental services, everything included in providing benefits. And as far as affordability, yeah, let us operate under how are we best going to make this affordable. And nothing is done in a vacuum. We need to communicate not only with finance and revenues tag, but all the other tags as well, because all of this work is interactive, and one approach, spills over into the other. And so, yeah, that's a good starting point.
Okay. Great. It's like policy making on the fly here. So I have just put up, I guess, to start, a couple of things that I've heard or I've kind of pulled out of the conversation that we've been having. And I'm wondering what folks think about these as kind of grounding statements. I mean, there's some overlap here, but grounding statements to start to dive into what would all services look like, essentially. So, okay, so I put the current set of healthcare benefits available to most Oregonians is insufficient. Consumers do not have sufficient control or autonomy over receiving the healthcare benefits they need to improve their health. There are barriers that prevent people from accessing the benefits they do have. Benefit design needs to address these barriers, and we need to be creative and ensure all services are able to be fully funded, no limits on services. What do people think about any of these statements, all of these statements? Are there other things you feel like, if we really are sort of building from the ground up here, having some kind of grounding beliefs about what this is going to look like? Do these resonate with you? Do you feel like these are accurate? I mean, I don't want to spend too much time on it, but I'm just trying to reflect back what I'm hearing in the conversation.
Sarah, I'm trying to use these statements in decision making about what this tag has to do.
Mm-hmm.
And I've heard it said, we value mental health and dental as an example. That's been said.
Yep.
I've also heard you say social determinants of health are important. That's been said out loud. Those are two examples of benefits. And I'm looking at these, and as a process thinker, I'm saying, how do I make recommendations about those as an example using these statements? How are these statements helping me make recommendations about, for example, do we put forth social determinants of health as a greater priority over dental and mental health? There are people at the table who would say absolutely not, or there are others that would say absolutely, because social determinants of health impact a far greater number of people and have much more of a public health impact. Because at the end of the day, even when we come together with finance, we have to have those kinds of conversations. So I'm looking at these and saying, how do these statements, which I agree are, we're starting to hammer out policy, which feels like an inexact method of doing what we're supposed to be doing. But nonetheless, I'm struggling with, real-time questions such as mental health, dental versus social determinants of health, or maybe I'm looking at this wrong and thinking, yes, we pay for all social determinants of health and dental and mental health, and we let somebody else sort this out. And then it becomes a cost issue, and the decision making that's occurring is based on cost, which is not where we want to be. So help me with real life examples and how we use these statements, if somebody could help me with that.
So I just want to say that I mean, you're right. So these are broad. They do not help you choose A versus B necessarily. I think that, for example, you could look at these and say, okay, the Oregon benchmark services are not sufficient to be able to reflect back these values. They do not address social determinants of health. They do not provide dental care for adults. So as that essential, like that Oregon benchmark plan that I presented before, would not meet, if these are kind of some of the statements that reflect the values of the tag and the priorities, the benchmark plan would not meet those. So whatever the tag proposes would be richer than that. I'm also hearing that versus, like, would I prioritize social determinants of health over mental health or dental health, is like not a distinction that, at least in this conversation, people don't feel like that is a necessary distinction. I think where something like that might come up is if there was a joint meeting with finance and revenue. But for now, I think there's a lot of passion behind not having to say mental health or social determinants of health. It's what people need, and what does that look like, is my sense of it. So I think, to, getting into sort of okay. So what I'm gonna do, and I think this was Xenia's suggestion, is I'm going to share a different screen with you. Okay, so hopefully you are seeing, this was the Excel workbook that I had sent out. I'm gonna hide this here. Where I went through and tried my best to put in the Oregon benchmark plan, the state employee plan, and Medicaid. These are not exact because a lot of the cost sharing and that sort of thing is really different. But as far as kind of richness of benefit levels, this is sort of where we landed. And so, Glendora, I think to your point of looking at what we have now and what's not working and what we want to build on, and Xenia, you talked about looking like maybe where some of the differences are. Maybe we can start here and see what people think. So I'll just tell you, I know we hate pegs, but I'm going to just tell you anyways, that our state employee plan is the richest of these three. So approximately, when I did all of this out, our PEB plan came in at 57 pegs. So for whatever that means, it was higher than both the Medicaid plan and the benchmark plan. And where that shows up is a richer benefit when it comes to primary care, a richer benefit in complementary medicine, so access to chiropractors, naturopaths, acupuncturists, richer dental and vision care, in Medicaid adults, and in the benchmark plan, vision and dental care for adults is fairly limited. And I think that's it. A little bit richer in home health. So if we, for example, took a PEB plan as a starting point, and took out cost sharing and took out prior authorization and took out limited service limits on quantities of services for now. From what I'm hearing in the discussion, places where people have talked about priorities for making this richer, for something that you would want to put forward, is around mental health and substance use, is around social determinants of health. Those are, I think, two of the big ones. So if we think about mental health and substance use benefits, I'm hearing that's a priority. What are the kinds of, statements or principles or specific things that you would want to make sure that they would be covered under whatever plan moves forward? So if we look at, I'm just going to pull up the description here, the examples that I used. So the highest level of mental health and substance use that I put, that was in this example, is that basically a plan gives you unlimited number of visits to a therapist or counselor, substance use provider on a wide network. You pay nothing per visit, so they're free, and you have an unlimited number of days in the hospital if you need it for treatment, and no hospital copay, essentially. That was like the robust mental health substance use benefit. So basically unlimited access to mental health visits, substance use visits, and hospitalization, inpatient treatment if you need it. Does that satisfy, or how would people feel about putting something like that forward as, this is what we want to see, this is what we would recommend that we need to be including in our plan?
Sarah, committee, I think that it should be that high of a priority and coverage, and we can label it as such, or we can recommend as such. I would move forward with putting that for mental health substance use for unlimited visits and care and hospitalization as needed. I think, and it's a whole different book, about the access to care. We can cover it, but having the access to it's where the dilemma is.
Sure. Absolutely. And I think, yes, for sure. I think we need to keep that in mind, and also know that there's other parts of the task force thinking about what that access piece looks like. But certainly.
If I have a question, and if I'm off base, steer me back. But mental health is we're short on mental health providers nationwide, not just in Oregon, but probably worldwide for that matter. If let's say somebody needs some type of mental health care, and the providers, you can't get them into a provider, or there's a waiting list of X amount of time before they can be seen, would this plan be able to have the network capacity to contract out in other states? Like if there's a provider across the river in Vancouver or Yakima or even Seattle, can our universal healthcare cover that for our patient?
This is Laurel. Nipper, may I chime in with some?
Yeah.
So Michael, that very question was raised at the last provider tag. The provider tag convened, I believe it was last week, and it was their final meeting, and they created a list of questions that they felt were unresolved, but still somewhat related to questions around provider reimbursement. And one of those very questions was, to what extent will this plan be reimbursing out-of-state providers? Specifically thinking about the scenario that you mentioned, if there is a patient that the closer provider is across the river or across the state border, as opposed to having to travel to Portland. The provider tag didn't reach any consensus around that. Everyone was generally in agreement that that the plan or that the report should include reference to this. They did suggest that it would be a place for EBA to weigh in. And so I think that that will be raised at the task force meeting. And I absolutely think it's within the scope of you all to be clear on to what extent out-of-state providers should be included in this plan. So I just wanted to offer that you folks aren't the only ones thinking about it. And in fact, it might be a place for EBA to specifically be offering proposals.
Thank you, Laurel. So yeah, Michael, I think you raised a really good point. And I think that certainly this tag could include in any recommendation that no matter the richness of the benefits package that is put forward, it does not address provider access. One potential solution or one potential thing that would help with that is ensuring that out-of-state providers could be included and reimbursed by the plan in order to address access issues, especially if the level of benefits that most Oregonians have access to is going to be increasing fairly dramatically. And so what does that do for access and provider capacity?
Okay, thank you. I don't want to steer us off of our PEG page.
No problem. Okay, I'm going to go back here. And I'm thinking, oh, sorry. 1 second. So to me, one of the places where I think there is the most potential for creativity and that would be a pretty significant change is around social determinants of health. So I want to just go back to what was in the document that I had sent out as some examples. This is a really new area in the sense that, the chat tool that I adopted this from didn't have anything related to social determinants of health. We know that CCOs are beginning to offer some flexible coverage that supports and addresses social determinants of health, but there's no like place to grab from and say another state is doing this, we want to make sure we also do this. So maybe it's just something to react to. The kinds of things that I had added in here that would reflect a high level of social determinants of health coverage would be support for a traditional health worker, social worker, community aide, or navigator to assist in housing, transportation, food, service coordination, or support for up to 60 days or events per year. Flexible spending might be available to support one-time or short-term needs. And so the examples that I gave here were, for example, there's a family that doesn't have stable and safe housing. This family is experiencing systemic racism and oppression in trying to get housing. And so the example was that essentially they have support from a traditional health worker, a social worker, they get an individualized housing support plan. They also receive funding required to cover their first month's rent and security deposit once their application has been accepted. The other example that I gave here was somebody in a domestic abuse situation who doesn't have she has employment, but no childcare and no public transportation. And so the examples were whether that person would potentially get, you know, up to 8 weeks worth of emergency childcare and 4 weeks worth of like Lyft vouchers or bus and train passes or whatever, so that she can get to work. As examples to react to when you all are thinking about services that support social determinants of health, I think there's a real opportunity to be creative and specific here, because like I said, there's not a lot of other language for folks to pull on. And you know, Xenia and Glendora, these might be areas where you know, your backgrounds and knowledge really can be just elevated here. But when you think of what you would want covered that would support SDOH, does this start to get at it? What else do you think about that you really want to make sure that families, or not family, individuals have access to?
When you give these examples, can you tell me what objective do you have in mind? Meaning, are these things that you're intending for us to consider in who provides this service with reference with the healthcare providers or the state? Tell me what.
No, I'm sorry.
Yeah, explain to me the purpose of these examples, because, okay, I'll stop there.
Okay, sure. Sorry. I don't think I explained that very clearly. So I think I'm hearing from the tag that putting forward some kind of benefits proposal that includes coverage of services that support social determinants of health is a priority. So maybe I'll just stop there and ask if that is the case, essentially. Is that something that the tag would prioritize for any sort of benefit package that was available as part of the plan?
No, as I said before, when we start prioritizing these kinds of social situations, then we're just perpetuating racism and classism and sexism and all kinds of other racial discriminations based on the provider's subjectivity. And I think we would be injuring, it would not be good. If we can, do we absolutely need these kinds of situations before we provide services that's going to be beneficial under this category?
No, Glendora, I was just trying to come up with an example that would give people an idea of what the services might look like. So,
if I can, Sarah, if I can just interject.
Yes, please.
I think and these are just examples, Glendora. So they're just examples. I think what Sarah's trying to hit on, the SDOH portion of it, is our social determinants of health, something that we need to cover. And yes, we do need to cover social determinants of health, because by doing so, we are potentially improving the lives of those people that are affected by those social determinants of health. Now, these are just examples, and they're specific examples, but you can have a listing of how those SDOs work, or how they're shaped. You don't have to be so specific to where they're pointing the finger out at something. I hope that clarifies what you're trying to say. I understand that we work on time here.
Yeah, I don't see this as people anybody intending to injure anybody else. Social determinants of health almost always require a conversation about what I mean. You know, when I give lectures in social determinant of health, half the time I'm trying to define them for the listener. because it's a new concept, even though it forms the base of the public health pyramid in terms of health outcomes and experiences. And I am for, Sarah, you asked specifically, does the group support social determinants of health? I want to be on record as saying that I am supportive of this as a benefit. And I think I heard others say that they're not. But I clearly want to say that I am supportive. However, it's described, we're going to have to educate each other within this group, within the task force, within the finance and revenue group, and the general public about what we mean. And I believe that these examples were an attempt to do that. And I like Michael's idea of listing, what is intended to capture. And also there are lots of groups out there that are trying to define what the package would look like. And I appreciate the work that's gone into this to bring us this far. And I bet there are other ways of really defining what social determinants of health, but I think we're gonna have to put energy into educating a lot of people that social determinants of health, investment in that infrastructure and that arm of public health pays dividends, because it's so upstream and it's so community based that we're finally flipping the pyramid and putting our money and effort where it needs to go. That's my opinion, and I am certainly want to be on record as being for this.
Yes, thank you, Dr. Jenkins. And I think you're right, and I may have jumped the gun here a little bit. I think having a clearer definition of what is on the table, what are services, what would be the definition of services that would support social determinants of health? What are social determinants of health? It may be necessary in order to move this conversation forward.
So, Sarah,
yeah.
I will also want to be on record of supporting social determinants of health included in the package. And I'm looking at our guideline principles that we have here, and we identify quite a few areas: the risk and protective factors, community risk factors, family risk factors, school risk factors, individual and peer risk factors, adverse childhood experiences. Those are all social determinants of health, and we have them identified in our health plan here in Warm Springs.
Yep.
I just want to say that I don't think there's anybody in the EBA group that is anti-social determinants of health. And my inquiry was not to suggest that they were unimportant areas to consider. I am just thinking from the perspective around at what point are these services addressed? And I may be jumping the gun. I may be confused, but with what are social determinants of health, I'm not confused. I live it every day. I want to know how and who will provide these services, and is that what are those the questions we should be asking? Are those the areas that we should be considering in determining how to include them in a comprehensive design? Not that they are not needed, because when I think about social determinants of health, I'm thinking about the benefits of education, nutrition, housing, the environment in which people live, and how these things impact our overall health and overall health status and the healthcare services. That's all.
Yeah, thanks, Glendora. I appreciate that framing a lot. I'm wondering, when you think, you've just listed out a lot of areas that are really important. When you think of having a healthcare plan that would support things like housing and nutrition and education, do you have an idea of what you would want that to look like? Like, if somebody has a housing need, how would the plan ideally be able to support that need? Or take another topic, you know, the environment or nutrition, or I'm just trying to get some ideas kind of out here.
Yeah, I think it would entail the at the point of recognizing and determining what a health consumer's needs are begins at their doctor's appointment. When they come in for an appointment, I am seeing that it may be helpful for those who are underemployed or unemployed, and even those who are employed, to discern what are their what kind of social needs do they have other than a physical mental health condition. Do they need housing in order to improve their physical and mental health conditions? So I'm thinking if they are evaluated for the needs of their external environments other than mental health and physical needs, that would help them to improve in those physical mental health areas as well. So that's how I see social determinants of health benefiting society. And that's how I see where it starts. So now how and who will provide these services is something that we should be concerned about as well.
Sure. So that's really helpful. I'm gonna say back to you what I think you heard, and you tell me if it's right. So as an example, if you have an individual who is having unable to make their rent, for example, or you know, it's housing insecure, would your vision be that they are going in and talking to a provider and saying, hey, it's not, you know, my leg's not broken, whatever, but I have this real need and it's affecting my health, and then working with their provider to figure out what can the system do to support that need, whether it is you know, a certain amount of money to like support the rent for the month, or I don't know what the other services would be, but that whatever they are is kind of determined at that point, a conversation between the individual and their provider.
I think that every provider should have some sort of a procedure in place to ask the question, and pending the response from their patient, they should have a social worker on staff that they recommend the patient to further discuss with the patient about the available resources and how to avail themselves of those particular resources based on need. That is how and who, that is my envisioning of how do we implement benefits based on social determinants of health. Does that make sense?
It does make sense.
Okay, so because I don't expect a provider to come in and address the needs of an individual who have any needs beyond physical and mental health needs. I don't see that as their role, but I do see it as a part of healthcare services.
Yes. So I think in order to make that a reality, in order to make that like something that can be implemented, and I'm interested in what other people think about this, I think we need to craft some kind of statement that's like, And this is what the range of options might be. Because and it could be very broad, it could, but I think having something, and maybe Michael, you said you have with the documents in Warm Springs, I wonder if that is something we might share with everybody, just as far as like what social determinants of health are, how are they defined, and perhaps, you know, what is covered, if that might be some helpful material as well. But I think we need to say, okay, that there's, you know, the vision, maybe a vision is that there's a universal social determinants of health screening, essentially. And out of that screening, an individual could get resources to support their housing, nutrition, physical health, emotional health needs. I think it would be smart for the tag to put some definition on what those broad breadth of services might look like. So yeah.
So Sarah, I agree with you. I wanted to see if I can, you know, pull this all together. I'm gonna launch from what Glendora says, and I agree. There's wisdom in us defining for the task force what we really mean. I, as a pediatrician, might see a brooding adolescent, and this adolescent has been cutting, and this adolescent has had other self-injurious behavior, and clearly it has affective disorder, or you know, there may be depression, and it's starting to exceed my level of expertise. I, as a primary care provider, am trained to recognize that there is an overlay of issues within the home, within the school. Maybe there's substance abuse. Maybe there's longstanding mental illness in the family. Do I have the time at the moment? I don't have the time to investigate that myself, and I don't have the expertise. I don't have the immediate people around me. In an Oregon health plan that, or in an ideal package, I would then maybe turn to somebody who is skilled in, you know, right now it might be a social worker, or it's a crisis worker, if it's specifically mental health. You know, I envision a plan where like any other member of the team, I've got a social determinant of health expert who would, you know, investigate the ACE score, you know, would head down that path of adverse childhood experiences, would start to align services in you know, other areas, or I'd have a health navigator start pulling in mental health, substance abuse, in-home visits, and, you know, start to pull in school counselors who may be part of the, you know, the benefits, or the providers. So that's where I see this all starting to kind of come together.
Mm-hmm.
I'd like for our group, as we're closing out today's session, to think about, you know, us having built beyond the PEB model, that column of PEB, as sort of the best model that's out there right now. It doesn't obviously meet everybody's needs, where we've seen some creative opportunities to add to it, including mental health, including substance abuse, and including social determinants of health, that we start to frame a recommendation that includes those types of recommendations to the other groups, so that we a little bit are closer to the task at hand. And you know, I appreciate everything that you're trying to do to capture these conversations.
Mm-hmm. Mm-hmm.
I just wanted to offer a couple of things. One, you know, there are some pilot programs, and I'm not sure if it's just here in the metro area, in which primary care providers are offered a space within their electronic health record to make a referral to a social service program, right? And there's a whole host of issues with that, at least in my opinion, including, you know, if a healthcare provider, if I see a patient in my clinic and I recognize that they need housing support, or they need to work, you know, they could use work with a community health worker or their traditional health worker, then I note in there that that is the resource, and then I send them through a pathway that is already being created and already been created to an organization to be able to get those services. The issue is that there isn't necessarily an influx of money or redistribution of funds to those organizations, right? So we're just like sending folks to a space where we know that there's not already services. So I guess for this conversation, what might be important is, you know, Ed, one of the things you brought up, which I think is really important, is like, don't have enough time, right? And part of that, I imagine, is a function of like time and capacity, right? Like, do I spend more time understanding this particular issue and kind of racking my brain for what I know are services, and the other issue is really based on, you know, insurance and otherwise, right? We only have a certain amount of time regularly that we are able to spend with patients. And so I think there's a couple issues. One, if we build a different system where we aren't beholden to the shortest visit possible, so that we can get as many visits in, so that we can get as much money as possible, and not us as individuals or the systems we work within, then maybe that gets to some of that piece, or we can spend a little bit more time understanding. But the subsequent piece about where if people get those services, what services are available, does the medical program cover the services that are referred, or do we have some way to interact and engage with public health or other social service systems, which are creating funding mechanisms for social service supports, and or I think about traditional health workers and, you know, reimbursement for traditional health workers, et cetera. Like, do those feel a little bit a little distinctly different? I guess a little distinctly different doesn't make any sense, but they feel distinctly different from just an umbrella of like, you know, this plan will cover all of these services. I believe the plan should cover as much of the social determinants of health service as possible. I mean, I think it's really integral to people's health and wellness. But I do wonder if, thinking about the existing pilot programs where the healthcare specific funding stops the minute that the provider has made that referral over to social services, who picks up the rest of those funds? If we're asking to move the rest of those funds under the, you know, our plan, then maybe we want to, you know, identify that, or if we want to identify where there's that intersection, not to cut it off, but to say, you know, we will pay for, you know, acute or moderate or whatever X, Y, and Z services, and or there may be a time, Sarah, to your example of like someone needs bus passes for, you know, a year. Maybe that's not this medical plan support funds the entire year, but perhaps there are like integration with existing services, transportation support, et cetera, that will pick that up after a certain time. I recognize that's, you know, wishful thinking, but I did want to just mention the pilot programs and
So there,
note, Ed, your comments.
Dr. Junk here, Glendora is the chair. That service is available through OHA. They have two separate services, one on the tribal level and one on the state level, and that's targeted case management, right? So you take that, like us as providers, we see these issues, we can refer them to a targeted case manager, and that targeted case manager is trained to identify those determinants of health, right? And then these are the services they need, whether it's housing, transportation, behavioral health, whatever, they identify that through targeted case management. And you use that social worker / traditional health worker as their navigator to ensure that they get those services. And each section of those services are billable. You know, the traditional health worker assisting them to help them get to those appointments to make sure that they're getting their needs met. And then the targeted case management is also reimbursable as identifying their needs and getting them to their services. So that does exist. It's been here for a while. I don't know about statewide. We've been utilizing it at a tribal level for many years, but statewide, I know that OHA does have targeted case management for their areas. How many are utilizing it? I don't know.
So Michael, that's exactly an example of the point I was trying to make when I said that we should be considering what do we have in place that works well, that is necessary, that you know, helps to at the end of the day improve upon the physical and mental health of the healthcare consumers. That's exactly what I meant by you know, giving some attention to in our attempt to make recommendations in designing a comprehensive benefit health plan. Thank you for that.
Yeah, thank you, Mike. I think what potentially would be new about this is that it wouldn't just be the coverage of the time of the targeted case manager or the traditional health worker, the patient navigator. It would maybe be funding for the services themselves, whatever it is that is identified, that would be maybe richer in terms of what would be funded through a plan that would come out of this. So if it's non-emergency, or excuse me, non-medical transportation, or nutrition classes, or whatever it is, that perhaps there's funding available for those things beyond what is currently available now.
And can I echo again what Xenia said, which is the time element. Right now, the incentive for providers is to blow through patients, and to allow for provider time, primary care provider time, to address upstream causes of healthcare should be reimbursed. Should be reimbursed and be valued. And right now, the current system doesn't value that. It values actually procedures over that kind of thing. So I just wanted to echo what she had said, because that is the reason why I'll see 8 patients in a morning when I really should be seeing 4 patients in a morning, and getting it exactly right.
Thanks, Dr. Jenkins. Yeah, so obviously this is really very fundamentally tied into issues about not just provider capacity, but how providers are supported by the system, and what they're incentivized to do and what they're incentivized not to do in terms of their time and their billing and reimbursement. So I am looking at our time. I want to ask if there's anybody here again who did want to offer testimony today. Okay, so I'm not hearing anybody. I think that we've had a lot of rich discussion today, and have, who all have grappled with some really tough things. I want to acknowledge that this is really, really hard. I'm thinking about ways to kind of move us forward here. And one thing I want to do is kind of, I've tried to capture what I'm hearing here, what I've heard from people. I would like to write that up a little more completely in terms of like what are value and principle statements and specific barriers to what's not working, things that people identified are working, and kind of write that up and organize it a little bit and send it out to the tag for people to give feedback on, and see if I've captured everything. I think I also would like to propose building on a PEB-like plan, understanding that what I've heard today is, no limits on services, no cost sharing. I think there's some more conversations that I would like us to have around cost sharing, about, maybe like upper income people. But we can do that in March. I'd like to have something more specific for people to react to, thinking about the conversations we've had about social determinants of health, mental health, about consumers really driving their own definition of care. I think there's a place for this tag to really weigh in on. There needs to be some description of benefits. Who has control over really determining those? So I'm thinking about developing something and sending it out for people to react to, and then we could further discuss it at the March meeting. What do people think about that?
Sounds good to me.
I think that'd be a good use of all of our time and your time. And again, Sarah, I appreciate the gymnastics that you've gone through to keep us on track and to keep us moving forward. Much appreciated.
Well, I
think
really
it's a great
appreciate
idea.
all of you to help us work through this very difficult topic here. Dr. Junkier, I'm sorry, I didn't mean to cut you off.
Oh, no, you didn't. Sorry. I had to hop on my phone, so it's hard for me to gauge the conversation. I was just going to say I agree that it would be a good activity.
Okay. Let's see. Michael, what do you think? I think we lost.
I want to thank everybody for their time today and moving this meeting productively forward. And I want to echo Dr. Junkins, and you're doing somersaults for us.
Okay, so I will do that. So you're gonna have a few different things coming your way for which I would really appreciate your feedback and comments. One is going to be the eligibility and enrollment draft proposal that will be presented to the task force in a few weeks. So that will be going out shortly. Separately, and this I probably will have out to you early next week, will be our conversation today, capturing what I heard, a draft proposal, trying to just have something for you to respond to that tries to reflect what I heard today, and that would be something that we would have more discussions in March, but that I would really like your feedback and questions and comments on before we meet in March, because that is right now our last scheduled meeting. I'm also kind of holding in my pocket what I proposed before, which is potentially a joint meeting between EBA and Finance and Revenue. And I know that there was some interest in maybe doing that, and I think we could think more about what that might look like in a way that's a good use of time for everybody. So if you have more thoughts on that, that's great too. But two different things I'll be sending you to react to and give me feedback to set us up for our March meeting. I think Glendora, and I apologize, here we are at 11:57. I know that you did put forward some of the EBA questions to the CAC, but I don't know if there's anything else you'd like to reflect on before we close today about conversations the CAC has been having related to eligibility enrollment benefits beyond what you shared at the task force.
No, not at this time.
Okay. Anyone have anything they want to make sure to get in or ask about before we adjourn for today? Okay, well, truly, I thank you very much for participating and engaging and working through these tricky conversations all together. And I look forward to getting everyone's feedback and coming back in March and seeing where we get to.
Sounds good. Thank you.
Have a great day, everyone.
Thanks,
Thank you.
everyone.
Bye,
Goodbye.
guys.
Bye.